Talked about the clitoris, the erectile structures of the clitoris. Okay. Let me just tell you a tiny bit more about that before we leave, because it's going to correlate directly to how erections happen in males. Okay, so the metaphor that I generally use about erections and how they occur in males, it's hydraulics. So I want you to imagine that this is a pool float. You with me with the pool float metaphor? Okay. And this pool float, it's not inflated yet. Half of it is stuck behind a fence. Think about that as your body wall. You with me? Okay. But the other half of it is flopping over the fence. Does that make sense? And then you start blowing the damn thing up. And since this part is smashed against the fence, then what's going to happen is you're going to wedge against this and use it as leverage so that the thing can pop up. And that's how an erection occurs. That makes sense? Okay. Because these crura, or singular crus, right? Those are behind the body wall, and then this is sticking outside the body wall. And when you increase blood flow, right, the hydraulics makes it stand up. That's how an erection occurs, unless you're a raccoon and then you have a bone in your penis. So a lot of animals have bones in their penis, but we don't. That will be on your test, and some of you will miss it. How's an erection occurring? There's a bone in the penis, and it unfolds. A whole bunch of things that are related to raccoons, not dogs, not cats, whales. Do birds have penis bones? Yeah, ducks have really aggressive penises. Ducks are rapists, just in case you didn't know. There's no consent involved in the duck world, so don't think they're cute. They ain't cute. He just like tries to drown her, right? And he's got barbs too. So this could all get worse, is all I'm saying. Okay, so here's how the penis erection works, right? Two paired corpora cavernosa, but the clitoris is, the erectile structures of the clitoris are similar to the erectile structures of the penis, right? Here's paired corpora cavernosa, right, that go into the body of the clitoris. They are continuous with the crus, right, which is sticking back behind. So when a woman is aroused, what's going to happen is you're going to start to blow up her pool float too, right? And the tissue that is behind the body wall will engorge and then cause the tissue that is outside of the body wall to pop up. Does that make sense? In addition, this is homologous to the corpus spongiosum, right? That makes sense? So that tightens the opening to the vagina, right? Good. So that's how that works. That's how this whole structure actually works. Everybody good with that? Now, has no actual reproductive function. The clitoris has no actual reproductive function. It is exclusively related to pleasure. Yes? Of course, does a woman have to have an erection in order for her to, for instance, get pregnant? Absolutely not. She doesn't. And she doesn't have to have an orgasm either, although we will talk about the fact that orgasmic women tend to be more fertile than women who are not orgasmic for some mechanical reasons, right? So, like I said before, what has happened historically, since this isn't really related to pregnancy and to procreation, and it was related to female pleasure, they just take the darn thing off, either in the textbooks, right? Or with female genital mutilation, also called female circumcision. You guys have heard of it before, right? So do you know what happens with that? It's cultural, and it's not just historical because it's still going on in some cultures. How you can, for instance, make it more likely that your daughter is going to be faithful to her future husband is they actually go and cut off the clitoris. They take it off. And sometimes they will also sew up the opening to the vagina so that it's a tighter opening to the vagina. And that is still happening in some cultures, some African cultures, some Asian cultures. Did you guys not hear that there was a Supreme Court case because a big, I think Sudanese, but don't assume that that's correct because I don't know for sure. But it was in Minnesota. There's a huge Sudanese, I think, population. It's a Sudanese Muslim population, but this is not part of Islam. This is part of that culture, right? A specific culture. Does that make sense? So they were doing, a physician from that culture was actually doing that surgery for people in Minnesota, the United States, and went all the way to the Supreme Court. and they got permission to keep doing it, interestingly. So anyway, that's FGM, female genital mutilation or female circumcision. And one of the fascinating things about it to me is it is generally the women that do it to the next generation of the women. So it makes a woman in certain cultures marriageable, that she has had this done. If she has not, then she is not considered marriageable in her culture. And so the grandparents will do it to the next generation will do it to the next generation, right? And sometimes it's even a sort of group cultural celebration that they actually do this. So interesting kind of thing that occurs. So that is female genital mutilation. Okay, so now we are ready to move from the clitoris to the ovaries. And the ovaries are weird little critters, so let's find them. Okay, so this is a posterior view. You may not have known when you looked at this that it was a posterior view. So the ovaries are sitting behind the broad ligament. You with me? Okay, so if I am the ovary and these are my uterine tubes or fallopian tubes, in order for them to actually go and fold over the ovaries, they go back like that. Does that make sense? So the ovaries are back there. They're weird looking. They're smaller than you expect them to be, especially for as much as they could jack up your damn life, right? So they are relatively small. They've got a weird texture. It kind of looks like large curd cottage cheese on the outside. So let's look at how they're actually held into the whole process. So the broad ligament sort of holds them, right? It's not actually attached to them, but it's kind of supporting them. And then you've got this one, which is the suspensory ligament. The suspensory ligament suspends them from the body wall, yeah? And then this ligament right here is called the ovarian ligament, and the ovarian ligament attaches them to the uterus. It's not a tube, though. It's just a ligament that's attaching them, right? Okay, so they are sitting out there. Note to self, they are actually not attached to the uterine tubes. When you ovulate, we'll talk about ovulation in just a second, you actually don't ovulate into the tube. You ovulate into the peritoneal cavity and hope that the tube picks it up. And we'll see that in just a second. So this is the ovary. So let's look at it in a little bit more detail. Ready? Okay. So let's look at the sort of structures and function of the ovary. The ovary has pretty much parallel function to the testes. Both sets of gonads produce gametes, which are 23 chromosome cells, right? Okay. And they also produce hormones. Yeah? Okay. Of course, the gametes should, on a good day, go into the reproductive tract, right? Whether it's a sperm or an oocyte. Yeah? And the hormones go into the bloodstream. Yes? Since the hormones go into the bloodstream, they don't just affect your reproductive tract. They can affect everywhere, especially since estrogen, progesterone, and testosterone are all lipid soluble. If they are lipid soluble, can they get into your brain? Yeah. And do they get into your brain? Well, yeah, they do, right? All of us have had that at some point, in which your reproductive hormones are actually impacting your mood or perspective or outlook or whatever, right? I've got a 12-year-old right now. He's like in the early stages of puberty. He is constantly telling me, I am so mad. I don't even know why. I am so sad. I'm going to cry. I don't know why. I was like, just have a snack, go read a book, come out. He told me the other day, he's like, Mom, I'm having a testosterone storm. I'm very emotional. I was like, I don't know where you came up with that term, but here's a snack. Here's your dog. Cuddle with your dog. You're not mad at the cute little dog. Okay, so let us look inside the ovary. Okay, blood supply first. How do the ovaries get their blood supply? Well, you guys know, right? Yes, the gonadals is the ovarian, and it's directly branched off the descending abdominal aorta, and those go to the ovary. There's also another branch. I didn't make you learn it before, but basically internal iliacs give rise to a branch that's called the uterine, and then the uterine artery gives rise to another branch that's the ovarian branch of the uterine artery. So let me just show you where that is. I won't ask you about it, but I just want you to see what I'm talking about. So here is the ovarian ones, right? But look, this one, uterine ones go to the uterus, but also go to the ovaries. Do you see that? Okay. So branch of the internal iliac ones. All right. So innervation of the ovaries, they have both motor innervation, primarily just control blood flow to them, and also sensory innervation. Some women can feel it when they ovulate. Some women can feel it as it actually busts through the wall of the ovary. So we're going to look at ovulation and everything now. So now let's look at a coronal section of an ovary. Okay, so let's just look at the tissue layers first. Okay, outer layer of the ovary is epithelial tissue. It is sort of continuous with the serous membrane. They call it the germinal epithelium. It's clinically significant because that's where ovarian cancer usually occurs. Interestingly, ovarian cancer occurs in like the tissue that isn't even particularly unique to the ovary, but this is where it generally occurs. Anybody remember with ovarian cancer why, although it's not super fast growing, a lot of women die from ovarian cancer? Anybody remember why? What'd you say? It doesn't metastasize very quickly, but it's really hard to diagnose because it just kind of irritates the peritoneum and you don't feel like your ovaries are messed up. You just like have a stomach ache, right? Because it's like in contact with the peritoneum, right? Or you have the squirts, or you're constipated, right? Or you feel like you've got uterine cramps. It doesn't feel necessarily like ovaries because it just irritates the whole peritoneum, right? And so what happens, instead of getting diagnosed in stage 1, it might be stage 3 before you get diagnosed. And the reason this is worth us talking about is because if you have a family history of breast or ovarian cancer, right, then you need to get your physician to take a month-long stomach ache very seriously. Yeah? Because this has a relatively strong genetic component. And breast and ovarian cancer, there's certain forms of breast cancer that are the same genetic mutation as the certain forms of ovarian cancer. So it's good for you to know that. If you have members of your family who have those, then you pay attention. And you also alert your physician, right? You want to give them as much information as possible to help make good decisions. Okay, so that's the germinal epithelium. Deep to the germinal epithelium, you're going to run into a layer of connective tissue. It's called the tunica albuginea. You also have one in the testes. In the testes, it's thicker because, of course, they're more at risk because they're outside the peritoneal cavity. And then you start running into the action part. Does it surprise you at all that the outer portion of the ovary is the cortex and the inner portion is the medulla? No. So the inner portion is not particularly like that interesting. It's just where all the blood vessels come and go from and the nerves come and go from. That's the medulla. The outer portion is the interesting portion. This is where the action happens. So you guys, of course, remember from biology, meiosis, right? And meiosis is the process of reducing your chromosome complement so that you can make a gamete, right? So you go from 46 chromosomes to 23, right? And there's meiosis 1 and meiosis 2. The first meiosis actually reduces the number of chromosomes, and the second one reduces the amount of genetic material. So what is going to happen is, in a woman, you are going to choose one of these 46 chromosome cells per cycle, and then that one's going to go through meiosis, and then it's going to get ovulated. Does that make sense to you conceptually? Okay, so let's talk about what you've been told and I've been told. You have been told many times, I would imagine, that a woman is born with all of the eggs she's ever going to have, but that's not true. What she is born with is all of the egg-producing structures she is ever going to have. But she's got plenty, 1.5 to 2 million. That's a lot even for Utah, right? Typically speaking, she is going to ovulate about 400 of those in a typical reproductive lifetime. The rest of them are just going to be reabsorbed, degenerate. It's called follicular atresia. Okay, so here's what's going to happen in a typical cycle in a woman. When the hormonal complement is just right, one of these guys, they're called primordial follicles, and you've got millions of them. One of them in one ovary is going to start going through the meiosis process. As it starts going through the meiosis process, the chromosome number is going to reduce pretty dramatically, but it has this big supporting bubble of fluid called a follicle that helps to support it until it's ready to ovulate. So when it is ready to ovulate, it literally has to bust through the connective tissue in the wall, right? And so some women can feel this when this occurs because you have sensation and you're busting through the tissue. Some women also spot when that's occurred. They have a little bit of bleeding or spotting when they ovulate. Does that make sense? Okay. Usually in most women, this is only going to happen on one ovary per cycle, right? And it doesn't go right, left. It just goes however the hell, whichever one's ready. It's going to pop one out. When a woman has fraternal twins, for instance, it is absolute evidence that at some point she hyperovulated, right? She ovulated more than one egg per cycle. Does that make sense to you guys? Okay, so here's what's going to happen, and then I'll show you an actual picture of this occurring. when they were harvesting eggs for IVF. So one of these is going to get ovulated. What generally should happen is that ovulated oocyte will get picked up by the oviduct or the uterine tube, right? And perhaps fertilized. If it gets fertilized, it usually gets fertilized right there. And then if fertilization occurs, then it might implant into the uterus here. But let's stick with this for just a second. So you ovulated. If you ovulated, it can be a week or 10 days before implantation actually occurs. This little supporting structure that was supporting the developing egg needs to continue to produce progesterone. Progesterone is progestation. What is progesterone going to tell your uterus to do during those 10 days? Build, thicken, hold. Hold, just in case, right? Once you get past the window, what's going to happen is you're like, maybe next month, this will degenerate. You'll start the whole damn thing over again. Does that make sense? Okay, so look at this bubble. This bubble right here is called a follicle. The bubble will move out to the edge, and then you are going to ovulate an egg from that bubble. And this is actually a picture of that occurring. It's kind of weird, a little gross, but also cool. This is like a baby picture of all of us, isn't it? This is like a baby picture, right? This is the youngest picture of you. So here's the ovary right here. What's this? That's the follicle, and what's that? That's the oocyte or the egg being actually ovulated. Pretty damn cool. This was laparoscopic with a camera for a woman that took like Clomid for hyperovulation. So if you're going through IVF or some kind of fertility treatment, one of the things they can do is they can give you a drug that makes you hyperovulate, and then they go harvest the eggs. Yes? And this one, they just happened to hook up a camera so that you could actually see what was happening, which is crazy and weird, and I really like it, even though it makes everyone slightly uncomfortable. Go ahead.
Egg harvesting, they don't wait for you to ovulate, though, right?
They can induce ovulation. Yeah, there are chemicals that you can use to induce ovulation. So you get them all really, what? No, they don't cut them out. They give chemicals that induce ovulation. They go look at both of your ovaries and pull any one out that looks like it's just about ready to come out. So pretty cool. So anyway, this is ovulation, the whole process of ovulation. It's really cool. It's really hormonally tricky though. Okay, so we've got those. Okay, the medulla we already talked about, the ovarian medulla. We already talked about the supports for the ovaries, right? We already got those. Okay, so and we already talked about ovarian cancer. So everybody good? Okay. All right. So now we are ready to move, of course, to the uterine tubes, also called fallopian tubes, also called oviducts. They're trying to move away from the word fallopian tubes, but it's the term that most people know. Okay. So the tubes that we are talking about are here. Here we go. So see our tubes. So my ovaries would be right back there if this is my uterus. Okay, so let's look at the regions of the tube. Okay, this portion right here that looks like a cup, that under the influence of high levels of progesterone will actually fold down over the ovary. That's called the that's called the infundibulum. It has little fingers that again become stiff during the influence of progesterone. Those are called fimbriae, which means fingers. So you've got the fimbriae, the infundibulum. This portion right here is called the ampulla. That's like right here on my wrist. That is the most common site of fertilization. Not implantation. You don't want implantation to occur there. But the most common site of fertilization is right there, which is interesting because it means that the sperm, right, has to make it not just into your vagina, but past the cervix, swim all the way through the uterus, all the way up to here. Yeah? And the thing that you guys need to understand, which is just weird as hell to me still, is that these actually aren't attached. Right? So although the fimbriae and the infundibulum will fold over on high levels of progesterone, it doesn't seal, right? So you actually ovulate into your peritoneal cavity and hope it makes it into your oviducts. It doesn't always make it into your oviducts. So you can have an ectopic pregnancy in which fertilization and implantation happen out here. And we'll talk about those in just a second. Does that make sense? So since this isn't closed, the egg doesn't always end up in there. And since this isn't closed, the sperm doesn't have to stay in there either. Does that make sense? And that's just weird. It seems like somebody should ask me permission before sperm goes swimming around someplace I didn't give it permission to go, right? Some consent would be nice right here. Okay, so the uterine tubes have two functions. It's, of course, the site that the egg moves, we hope, right? But it's also the site of fertilization. Most fertilization does not happen in the uterus. Most of it happens in the actual tubes. So as far as the tissue layers, do you guys remember that we said way back at the beginning of the semester that these uterine tubes have ciliated epithelium, right? It's ciliated simple columnar epithelium. And the ciliated simple columnar epithelium along the wall will start waving to, we call it courting the oocyte. So it's courting it in. In addition, it's got smooth muscle in its wall. So the smooth muscle will start to contract this direction, and the ciliated cells will start to wave this direction. And what apparently works pretty well, because there's 7.5 billion people on the planet, that should get the egg into the uterine tube for fertilization. It doesn't always, but it quite often does, right? So that's called courting the oocyte. Okay, the other portions, so we had the infundibulum with the fimbriae, the ampulla, which is the most common site of fertilization. The green portion is the isthmus. And then this portion where it sort of pokes into the uterus but hasn't opened up yet, that's called the uterine part of the uterine tube. Everybody okay with that? Okay, so as far as clinical notes, have you guys heard of PID, which is pelvic inflammatory disease? Okay, so let's talk about pelvic inflammatory disease and how it's related sometimes to ectopic or tubal pregnancy. So here's what can happen in a woman. It could be a pathogen that you were exposed to because of sexual activity. And that's really common, of course. If there's another person involved, they probably have different flora than you do, right? And not all flora in the other person is pathogenic, but it could be, right? You could get exposed to chlamydia or gonorrhea, right? You could also get exposed to some asymptomatic STD, or you could have a pathogen that isn't associated with sexuality at all, right? You could have one that moves from your urinary tract to your vagina. Does that make sense? You could have one that moves from your digestive tract to your vagina. Regardless, what can happen if you have a pathogen is that it can irritate your reproductive tract. Yes? Okay. It may be asymptomatic. You may have never known that it occurred. So this pathogen that can irritate your reproductive tract becomes problematic if it actually damages the tube, because the tube is relatively small to begin with. So here's what would happen upon fertilization. With fertilization, it would go out here, right? Fertilization occurs out there. Immediately after fertilization, you'll start cell division. 1 to 2, 2 to 4, 4 to 6, 8 to 16. So you're getting bigger, right? As you get bigger, this is usually big enough to let a normally developing structure go through it, right? But if you damaged or scarred the wall of the uterine tube, you can cause problems with that fertilized egg actually being able to get through. Does that make sense? Like it just gets too big to go through the blockage. And then fertilization could not result in implantation in the uterus. You might try to implant it in the tube. That's called a tubal pregnancy, which is a type of ectopic. Ectopic just means out of place, right? It's out of place. So you can try to implant it in the tube. And those pregnancies, if you peed on a stick, you would still produce HCG, which is human chorionic gonadotropin. You would still have a positive pregnancy test. But within a couple of weeks, you would have a lot of pain associated with it. And here's the important thing. It can't be carried to term. If the woman tried to carry it to term, she would probably die. It would end up causing hemorrhage in the woman. So it can't be carried to term. You have to actually get rid of it in one way, shape, or form. Okay? The other way that an ectopic pregnancy can occur is not in the tube, but somewhere out here. So if fertilization and implantation occur out here, it can implant onto a mesentery, onto an intestine, onto urinary bladder, right? Those can't be carried to term either. So you have to get rid of that thing or it's going to kill the woman. It's also very, very painful to do those things. The only two that I have found in the literature, ectopic pregnancies that have been carried almost to term, they carried to a live birth, but one of them I think was 27 weeks and the other one was 29, so it's still really preemie, super duper preemie. Were two ectopic pregnancies in the literature that implanted on the outside of the uterus. They had access to the same uterine blood flow, and they actually ended up making, a placenta because they had access to this blood flow, right? And so, like the amniotic sacs were out here. Does that make sense to you? Really, really dangerous for both women. Of course, they couldn't do vaginal delivery. Tubes aren't hooked up, right? So they had to do cesarean sections, and they did them late, right? But barely viable late. And one of the babies lived and one of them didn't in that situation. So this is an ectopic pregnancy. So this is interesting to talk about right now, especially in this particular political environment, because all over the states, that they are putting into legislation limitations on when a woman can terminate a pregnancy. And it's happening all over. For instance, in Texas, where I'm from, they're attempting to pass legislation that makes women who have abortions punishable by the death penalty. Yeah, that legislation is going through in Texas. And other states, including here, there's legislation right now being considered that says women cannot have a terminated pregnancy past 18 weeks, past 20 weeks. I want you to understand that is these women quite often, right? These women who have pregnancies that can't be carried to term, now we are trying to say that you can't terminate that pregnancy. You have to try to carry that pregnancy to term in situations like this. In situations in which the baby isn't viable or the pregnancy isn't viable, still these legislations that are happening, if you look at the literature and if you go to a reputable source that's actually peer-reviewed, you will figure out that the vast majority of women who terminate pregnancies past 20 weeks have some kind of anatomical or physiological abnormality with the pregnancy or the women or both are at risk. And now what we are trying to do is keep women from being able to make these kinds of decisions. Go ahead.
So you're saying that there's no gray area for a life or death situation?
No.
And not very...
In Kentucky, for instance, they just passed one, and the governor, I think, actually signed it, which was nothing after, I think it was 20 weeks in Kentucky. And there's one going through the Utah legislature right now that's actually about this kind of stuff. So regardless of what your particular perspective is on that, and you may go vote just because you disagree with every damn thing I say, and that's a perfectly reasonable reason to vote. It's half the reason I vote in Utah, honestly, right? I would like for you to be well educated about the implications of these things so that you can actually make your own decisions with your own voting booth, right? And you don't have to make mine. I just assume that here in Utah, nobody agrees with me. I just pretty much do. But I do want you to actually know what's going on. So these kinds of things are not exempted. And of course, a lot of times in Kentucky, rape and incest isn't exempted as well, not even pregnancy problems like these. So because it would actually be terminating a pregnancy, even if it was a non-viable one, it is actually limited in certain states now here. And of course, Utah is pretty restrictive, but not as restrictive as some states. Okay, so that's ectopic and tubal pregnancies. They're kind of interesting. They increase in likelihood with PID. PID doesn't have to be because of an STD, but it is more likely, right, when you're sexually active, right? You're more likely to be exposed to pathogens when you're sexually active. Okay, so now let's move to the uterus, okay? So when we move to the uterus, of course, this is the womb, right? This is what has to implant, support developing embryo and fetus. Generally speaking, I'm not trying to offend anybody by using these words, scientifically it's an embryo until about 6 or 8 weeks. And it's a fetus from 8 weeks or so until it's born. It's actually called a fetus physiologically and anatomically. So it's called a fetus during that particular time. When it's born, it's an infant. Okay, so that's what these terms actually mean. So let's make sure that you can find the uterus on both the mid-sagittal section, right? Okay, urinary bladder, uterus. All you have to do is follow the vagina up and you're going to find the uterus. Of course, you should be able to find it on this as well, right? This is a posterior view. The portions of the uterus, this is the fundus, fundome, boink, always looks like a trampoline to me. This portion right here is the body of the uterus. As it starts to narrow, it is the isthmus, right? And then as it projects into the vagina, it's called the cervix. You probably won't be surprised that an awful lot of women have had babies and don't know what the cervix is, and have had Pap smears and don't know what the cervix is, but you are not going to be one of those women, even if you were when you got here. So let's talk about the size and the shape of the uterus. It's smaller than you expect it to be. Were you kind of surprised how small it was on the cadaver? It's pretty small. In a woman who hasn't had a almost full-term or full-term pregnancy, it's about the size of a pear. In a woman who has had a full-term pregnancy, it's going to be a little bigger forever, but then everything else is too, let's be honest. Just everything, right? You're like, that used to be tiny. You're like, well, that was a different time. Okay, yeah, the before picture. Okay, so as we did the parts, let's talk about how you hold on to it. This one I'm not going to hold you responsible for because they actually don't have it labeled in the picture. I'll show you where it's supposed to be. But what's holding on to the uterus, in addition to the one that we've already learned, which is the broad ligament, right? So that kind of is in front of the ovaries and behind there. There's this guy, which is the uterosacral ligament, but the only one that you have to know is this round ligament, and the round ligament is weird. The round ligament actually goes from the uterus and it goes down through the inguinal canal and inserts onto your labia because it's actually homologous to a structure that is useful in males. Yeah, you can have round ligament pain. Yes, that goes out there. So it doesn't really help support the uterus in women, but its function in males helps you understand why you've got something parallel in women. So it just kind of goes to the outside, out the inguinal canal. This is weird structure. Okay, so the other thing that supports the uterus is important, and that is your pubococcygeal muscles, the muscles in what we call your urogenital diaphragm. Does that sound familiar? All of these skeletal muscles right here, those being intact and having some muscle tone to them helps keep your junk up in there. Now, I know it sounds crazy, but it is true. If a woman has a whole bunch of big-headed babies, you can rip the living hell out of that thing, and you can actually have what's called uterine prolapse. And uterine prolapse is when your uterus flops out, right? It doesn't actually come out of your body. There's still skin down there, but it flops out. Your urinary bladder can do that as well. Now, wouldn't this be good for teenagers to learn as they were considering having sex? You're like, no, your damn junk's going to fall out. And then the girl's going to go, no, you keep that. I'm not interested. I don't want any of that, right? It's better than abstinence only, like, oh, your junk could fall out, right? You could get a pregnancy on your urinary bladder and they're all like, no, so that's uterine prolapse when that thing flops out. That won't happen to most of you. Okay, so that's the muscles of the pelvic floor. So now let's look at the tissue layers. And this is interesting. It's also confusing as hell. If you go into the inside of the uterus, you run into 3 tissue layers. The endometrium, I know you've heard of because you've heard of endometriosis, yes? The myometrium is going to be made of what kind of muscle? Yeah, smooth muscle, thick smooth muscle, right? Because it has to help during birth or parturition. Everybody okay with that? And then the outer layer is the perimetrium, and the perimetrium is really just a serous membrane, right? And you got some connective tissue in between all of those layers. So the endometrium is a weird freaking tissue. It doesn't exist anywhere else in the body, and it only exists in placental mammals, okay? So let's talk about the endometrium. You ready? Okay, so if we look at this picture down here, we see the myometrium. That's the smooth muscle. Everybody with me? And then the endometrium has 2 layers. I don't usually ask you to identify them, but I want you to understand what happens with them. Okay, under the influence of hormones, what happens in a woman is, although I have a basal layer always, I will make a functional layer every single cycle. So under the influence of hormones, the basal layer will start to go through cell division and make a functional layer. This is tissue. It's really, really vascular tissue. And what is it for? What is it waiting for? Yeah, it's waiting for implantation, right? So it's super duper vascular tissue waiting for implantation. Everybody okay with that? Okay. You make a new one every cycle, and then when implantation doesn't occur, your hormonal change will cause it to slough off. This is the only tissue that we have that does this. Like, I'm going to make it and then trash it every cycle. Make it and then trash it every cycle, right? So when you menstruate, you do not menstruate blood, you menstruate vascular tissue. Yes, it is supervascular tissue. Does that make sense? Okay, so you're losing this vascular tissue off the inner wall of your uterus every single cycle. Everybody okay with that? Okay, so this is the endometrium. Now this one stays. There's also a bunch of glands in there because there's some functionality with the glands preparing for a pregnancy. So with that, of course, we're going to lead to endometriosis. We're going to talk about that in just a second. Before we actually get to endometriosis, let's just talk about where the uterus gets its blood supply, right? So the uterus gets its blood supply from the internal iliac arteries. They're going to have a branch called the uterine branch of the internal iliac arteries. It shouldn't surprise you that it comes from the internal iliac arteries, right? Okay, so let's talk about endometriosis. It is a freaking tragic mystery is what it is. The whole story with endometriosis is simply this weird-ass tissue that loses its way and starts to jack everything up. Here's what happens in a woman with endometriosis. Under the influence of her normal hormonal cycle, instead of just growing this tissue in the inner lining of her uterus, it starts to move out of the uterus. And it moves into, for instance, the oviducts, right? But it's not even limited to the oviducts because these little bastards are open, right? So it can move out of the reproductive tract and start to grow on your urinary bladder, on your intestines. It can grow all the way up to your diaphragm. The only thing that keeps it really from being a cancer is that it actually is limited to here. It doesn't go any further than that. But what happens is every single cycle with this woman, she will thicken it, and then when her progesterone drops, she will slough it off. It doesn't feel good when it sloughs off from here, but evolutionarily, that is really evolved to do that. It feels like living hell when it sloughs off the wall of your urinary bladder, your intestines, the bottom of your diaphragm. So it pulls that tissue off, and it's super duper painful. In addition to being super duper painful, can you see why pulling it off of the wall of here increases the likelihood of scarring and infertility in your tubes? Does that make sense? So every single month, what happens is it goes up, it comes back down, it goes up, it comes back down. So endometriosis increases the likelihood of infertility in women really dramatically. And they sometimes get it really young, like as young as when they started menstruating, right? So you can have it from 12 or 14. And what the hell is it? What causes it? Well, it's got a genetic component, but not very strong. So your mom didn't have to have it, but if she did, you're slightly more likely to get it. It's really, really influenced by your level of hormones. But if our level of hormones were the same and we were the same age, it doesn't guarantee that I would get it and she wouldn't. So it's not really predictive about your hormones. One thing that sometimes they do with it is that if I can screw up what's happening with your hormones, maybe I can interrupt the cycle of endometriosis. So if you have like a 12-year-old girl who's got the symptoms of endometriosis, even if she's not sexually active, sometimes they'll put her on birth control because you can interrupt the cycle. They also say that sometimes pregnancy will interrupt the cycle. If you can get pregnant, then sometimes endometriosis won't come back. But that's a pretty damn hard decision for a relatively young person. When I was in grad school, one of the women that I was in grad school with had pretty severe endometriosis, super duper painful, debilitating when it was really bad. And her physician told her, and she was 20 at the time, that probably the best thing that you can do is get pregnant because it might interrupt the endometriosis, and also this might be your only chance for pregnancy, right? Now, I realize in Utah, getting pregnant in 20 does not sound shocking, but to the rest of the damn world, it does, right? You're like, what the hell are you talking about? So she chose not to. She chose to get her PhD instead, and she doesn't have any children, but that's what she chose. So I want to show you a picture of endometriosis so that you can see what it looks like when it's actually growing on different places. So what you're looking at is the top of the uterus right here. These are sites in which you've got endometriosis. This is the ovary with endometriosis on the surface of it. So what do they do with endometriosis? They'll try to treat it hormonally. If that doesn't work, they'll go in and do an ablation in which they either surgically or with heat remove the endometriosis, and sometimes it comes back and sometimes it doesn't, right? And there really isn't any absolutely dependable cure for it. Sometimes it works in some women, sometimes it doesn't in other women. But it is pretty debilitating, and a lot of times it's very, very long term with what goes on with that. Does that make sense to you guys? And what?
Terrible.
Yeah, I think it is terrible.
Really terrible. So, sorry.
That's fine.
So, let's say a woman has endometriosis,
Mm-hmm.
and then she goes through menopause. Is this going to stop?
It's sometimes the only way they stop it is to do a radical hysterectomy. It will just take out all your junk, right? And then you're going to have to replace your hormones, but usually like it's going to go away because there's no endometrium for it to come from and to, right? But that's a really difficult decision for a woman who's 22, 24, 27.
Plus anything implanted on, you still have those issues.
Oh, it's still going to have scar tissue and damage there. Yeah. Do you want to share anything about it since you know?
Yeah, I don't care. I don't know. I mean, it depends which method you do and kind of what you believe, but with the excision instead of the ablation, it's going to be equivalent to like, think of mowing your lawn. You know, when you're mowing your lawn, you would just mow off the weeds versus like pulling out the weeds from the root.
Oh.
That's what my surgeon compared excision to.
So with excision, you actually go in and instead of just burning off the surface, you actually scoop out
Yeah,
the
I
tissue.
really like
That doesn't sound
cutting it
comfortable
out.
either.
I have a video of my surgery. But yeah, and that's supposed to be more.
Less likely to recur.
He says usually, I think in like 20% it reoccurs.
Oh,
Those are,
interesting.
Like, crazy. But the problem is if it does migrate elsewhere and they cut all that out as well, they're still going to deal with some scar tissue.
Mm.
So like for example, since it was on my bladder and there's scar tissue on there, I still pee all the time. And I feel like
Oh.
pressure. So it's kind of just a lose-lose.
Did you have a family history or no?
No one that was actually like diagnosed because you can only be diagnosed surgically, but from symptoms alone, yeah.
Oh, interesting. Yeah, it's pretty tragic. I'm hoping that research will find something out about it soon. But it's a bit of a mystery disease. We don't have that tissue anywhere else. There's nothing to compare it to. So we literally only have cases of endometriosis to compare to other cases of endometriosis. It doesn't behave like any other disorder at all. It's bizarre.
That it's super rare, but it can migrate to the brain. I have found it in a few.
What the what? How does it get up there?
And they've actually found some in like fetuses too as well. Don't know how or why.
I'm gonna look that up. How the hell would it get to the brain?
Why? Super rare.
It doesn't usually go past the diaphragm. It's usually just like growing down in here. But it sometimes grows all the way up to the diaphragm, like on all of the organs. It's crazy. But a lot of women, when it gets that severe, they're just like, take it. Just take it all, right? I can't deal with this anymore. Okay, so let's talk about cervical cancer. So cervical cancer is something that is preventable. So that's the happy part of this, okay? So here's your cervix. Your cervix is your baby holder inner. Yeah. That's what it's supposed to do when you're pregnant. It actually gets a little mucus plug. That's sexy, right? Mucus plug in there. Oh, yeah. Let's talk about mucus plugs. So get a little mucus plug in there, and then it's really tight during pregnancy. Hopefully it'll stay closed and keep the baby in there. But the other thing about the cervix is for some freaking reason, we do not know why, the cells, the epithelial cells lining the cervix actually have a not very low risk of cancer, especially when they are exposed to a virus. Okay, so there's a virus that most people have when they're sexually active, and it's called HPV, Human Papillomavirus. Okay, about 70% of sexually active people in Utah have HPV of one form or another. Yeah, I know. Okay, so let's talk about this. So in women, the reason that you've probably learned about this is because if you have any form of prescription birth control, what you are going to have to do on about a yearly basis is to go in and have what we call a Pap Smear. And with the Pap Smear, you would think it was named for the virus, but it's not. It's named for the guy who found it, which is, his name is Papa Nicolau. That's a good name to say, right? So what they do is they take a damn freaking tiny little toilet brush. Ask the women in your life about this because you need to know, and then you can tell them about your prostate exam. Okay, so because we can all be compassionate to one another. They take a little brush and they scrape the thing, right? And they send off those cells to a pathologist, which is basically a really good histologist. And a good pathologist knows the difference between normal cervical cells and weird-ass looking crazy dividing cervical cells. And if you have this happen, what happens is you're going to get a card or a phone call that tells you that you have an abnormal Pap smear. That doesn't mean that you have cancer, because this cancer is really, really slow growing. You can be in the precancerous stage. So if you check it every single year, you can catch it before it goes cancerous. Yes? Does that make sense? So if, for instance, it was abnormal, you'd probably have another one in 6 months instead of in a year. Yeah, to see if they actually got it. You can do an ablation. You can pull that stuff off. They can surgically intervene as well. So the interesting thing about this is that since they started, and it doesn't have anything to do with reproduction, by the way, since they started requiring this for women to have prescription to birth control, so many fewer young women get cervical cancer. Even if they had an abnormal Pap smear, you can take it at that point. Most women who end up with cervical cancer have never had a Pap smear, right? Because this is your check mechanism to make sure nothing is going wrong down there. So is cervical cancer deadly? Well, it's not very fast growing, but if you don't catch it quickly, it can kill you like every cancer can. But the really, really good part about this is that most cervical cancer is associated with exposure to HPV. So for whatever reason, those cells getting infected by the virus, which is usually, by the way, asymptomatic, causes them to divide abnormally and leads to cervical cancer, right? Okay, but we now have a vaccine for HPV, which, if you protect from HPV, you protect from most forms of cervical cancer, yes? It reduces women's likelihood of getting cervical cancer. It's called Gardasil, yeah? It's been available for at least the last 10 years, maybe a little longer. And the age groups that it's available for keeps expanding, yeah? First, it was just relatively young girls, and then basically the FDA has to test it in these particular population groups and ensure that it's both safe and effective, and then you have to test it in another population group. So I think now it's available for women into their 40s, yes, into their 40s, but insurance doesn't cover it all the way up to the 40s yet. They probably will soon. And then they had to test it in men. We have in Utah the lowest rate of HPV vaccination in the country. And our rate of HPV vaccination in men is abysmally low. So why is that? Well, men think, well, I don't have a cervix, so I'm not going to get cervical cancer. I want to tell you that HPV causes nasty cancers in men. Even if your partner didn't get cervical cancer, it causes mouth cancers and pharynx cancers in men. And most men don't survive those. So it's a really, really aggressive kind of cancer. So my son is 12. 11 or 12, I think, is when boys can get vaccinated against HPV. So I had the conversation with them because I was like, I'm not going to shoot you up with something now that you're like old enough to have opinions. Let's talk. This is what HPV is. This is what it could cause in your future partner. This is what it could cause in you. Do you want to get this vaccination? And I knew him well enough to know that he was probably going to choose to get it. So, but then he chose to get it, and it's actually 2 different shots, 6 months apart. He because his freaking wheels are always turning, he's like, wait, mouth cancer in men? How does that occur? And I was like, oh my God, I was not ready for this. Why did I not predict this conversation was going to happen? I was like, would you like ice cream or a car? What would you like? How can we get out of this conversation? So I just let him sit there, and I was like, well, kind of the way you think. And he's like, ugh, grown-ups are disgusting. But you're getting the vaccine. So anyway, he ended up getting it. So in Utah, we have really, really low rates of vaccination. And in part, when I talked to my OBGYN, who's a research physician, about it, he's like, I was like, tell me why you think this is. And he's like, well, we have this purity culture, and we assume that everyone's going to be a virgin when they get married, so they don't have to deal with this. But your partner is your partner, and totally separate entity than you, right? And they may or may not have had sex, regardless of what they tell you, FYI, right? Everybody lies about that, okay? And you don't actually have to have intercourse. You can have oral sex and actually get this as well. And that is pretty rampant among this community. I would just like to go ahead and tell you that, okay? It is. So your partner, and then males don't get it because they don't think that they're going to expose to any kind of cancer. So what my OBGYN told me, I think I might have mentioned this to you guys, he told me that the only way that he has convinced a bunch of Utah parents to get their kids vaccinated was that he told them, well, sure, your kid is going to be a virgin when they get married because, of course, little Johnny and Susie are going to be virgins when they get married. And even though if they weren't, you wouldn't want them to get cancer, right? He said, kids get sexually assaulted, women get sexually assaulted, men get sexually assaulted, right? And you want to protect them from cancer. So he said it was one of the saddest things that he's ever figured out was that parents were far more likely to protect their kids when they thought about the possibility of them getting sexually assaulted than if they thought about the possibility of them having consensual sex. But he did actually get a lot of his patients to get their kids vaccinated by that way. So anyway, we have a really, really low rate. It's not a super invasive vaccine, and it doesn't protect you against cancer. It protects you against the pathogens, right, that increase the likelihood of getting cancer. So it reduces your likelihood of cancer really dramatically. Two of the forms of HPV cause about an 85% likelihood of cancer in women over a 10-year period. So it's not even small. Like exposure to two of the forms of HPV are super, super likely to cause cervical cancer in women. Okay, so that's cervical cancer. Okay, so now the vagina. Vagina. Make sure that you can find the vagina, just as a general rule, but also on this picture. Here's the vagina, right? Urethra, vagina, anus, and rectum. Good? Make sure that you can also find the vagina on this picture, right? You should be able to find the vaginal orifice, the opening to the vagina. Can't actually see the vagina itself. And by the way, this isn't usually open like that. It makes it look like it's just sitting there going, I wish I had a penis. No, generally the walls actually touch one another whenever you are not like spreading your legs, right? This is how it's always represented, but this isn't actually how it exists in a woman. The walls actually touch one another. Because this looks like, hey, just give me some pathogens. Just like, come on up here, right? No, it's actually like the walls touch when the woman is not aroused sexually. So it's not just like sitting around like that. That's porn. Okay. So, all right, so the functions of the vagina, three things really. If an egg doesn't get fertilized, that's how you get it out, right? This is also, of course, the birth canal. That's how the baby makes it out. Not mine, but most babies, right? Mine was a cesarean section, okay? My son was actually comforted when I told him that. He's like, I'm really glad. I just learned all about vaginas, and I'm really glad that I've never been anywhere near yours. And I'm like, that's a weird thing to say, but okay. And then in addition, of course, the vagina will receive the penis and semen during intercourse. So that's the triple functionality. As far as the inner layers of the vagina, so this is a postmortem, huh?
I said it's a triple threat.
Exactly. This is a postmortem photo of the vagina. This is the cervix right here, right? This is the vagina. You see the rugae, right? And the rugae have two functions. First, of course, they stretch because you can get a baby out there, right? And second, the rugae also increase the friction on the penis to make likelihood of ejaculation increased, right? So that's sort of the double functionality of the rugae. So the portion of the vagina that surrounds the cervix right here is called the fornix, and because it stands for fornication. And apparently, although this just sounds so damn weird to me, the fornix has a whole bunch of nerve endings. But I don't know who the hell gets up there. I suppose it's a worthy goal, but like, this is like, what are you going to do up there, right? So there's a whole bunch of nerve endings up there, so I don't know. Give you something to do.
Make sure you know, like, hey, don't go any further.
That's true. Maybe that's it. It's all like pain. So I like, back off. So this is the fornix right here around it. Okay, so if you go to the tissue layers of the vagina, hopefully you guys remember that the vagina is lined with moist stratified squamous epithelium, right? Okay. And it's moist stratified squamous epithelium. It also has some extra glands in it that we'll talk about in just a second. The glands actually secrete some stuff. And you've got some connective tissue underneath it, and you've got smooth muscle in the wall, right? And then it doesn't have serosa it has adventitia because it's all like stuck into this connective tissue around the outside. That makes sense? So it's not just hanging out there. So the inner layer of the vagina, called the mucosa, this mucosa layer, it actually has secretory capacity. And it secretes and lubricates the vagina, but it's not just lubrication, it's also protection. So it actually secretes glycogen. Do you guys know glycogen? It's just like stored sugar, which when it hits the lumen of the vagina becomes fermented. So the vagina is always slightly acidic. And the acidity makes it inhospitable to most pathogens. So most pathogens get killed off by the acidity of the vagina. Does that make sense? My physiology professor always called it the hostile vaginal vault. And he always liked to say that some are more hostile than others. And I was like, that's probably you, dude. Look within. That's all I'm saying. Okay, so secretes glycogen, which gets fermented. It's hostile to pathogens, but sometimes vagina is hostile to some sperm and semen as well. And that can cause fertility issues, but it's actually an evolutionary protective mechanism. So my background is in evolutionary biology, so I love any of this crap. But in mammals, which is what I know the most about, including humans, there are a lot of protective mechanisms that keep people and mammals from mating with somebody they're very, very closely related to. Does that make sense to you? Okay. One of the protective mechanisms is that you just don't find your relatives attractive at all, right? So when I was growing up and people would say, your brother's super hot, and I'm like, that is repulsive. I don't know what you're talking about. Objectively, from like 25 feet away, maybe, right? But if you don't find them attractive, they also smell weird, right? I don't know if you guys know this, but we actually react to the scent of other people's bodies. And like, if you were heterosexual and there was somebody that you were heterosexually attracted to, it works with homosexuals too, but since we're talking about breeding, we have to stick to heterosexual situations. Sometimes, have you noticed that some people smell like hell yes? Yes? And some people smell like no. Like absolutely, positively, I don't care what you look like, you know, this is never going to happen. That's an evolutionary protective mechanism. Typically speaking, people that you are closely related to do not smell like yes. So that's one of the mechanisms. One of the other mechanisms is that your body tries to protect you if the genetics won't work. And the genetics don't work dependably with people you're very closely related to, but sometimes it's just a random person that just doesn't work with. So if you have sex with someone and your vagina is irritated, inflamed, and sloughs off, that probably tells you that you shouldn't make a baby with that person. Right? It's like, hell no, get it out. And it often happens in mammals when they're closely related. So even if it occurred, it's hostile to the sperm or the semen, and it generally irritates the living hell out of a woman. And every once in a while, some people just like stay in relationships like that. My sister-in-law, my brother's sister, one of his sisters, had a 10-year relationship with a dude that every single time they had sex, her vagina sloughed off. And I was like, I don't know what the hell you're doing, man. Heather, nature is telling you no. And he's not even funny. So you probably should just move the hell on. Finally, she did. I'm glad they didn't have babies because I was pretty sure I was going to have to be an aunt to somebody with 4 heads. That is the hostile vaginal vault. Okay, so the opening to the vagina is the vaginal orifice, right? And we know where that is. I do not know why your textbook did not put in the hymen, because the hymen has evolutionary significance, cultural significance, and we know about it, but your textbook left it out. So this is the vaginal orifice, but the vaginal orifice is partially to completely covered with a strip of tissue at some points in some women. It is not dependable in every single woman. Here's some variation of hymens, but there's a lot more. Okay, so let's talk about what the hymen is. Okay. So with a normal hymen, most women just have a little strip on the bottom side. And here's an imperforate hymen. This hymen doesn't have any big holes in it. This means that this woman, if she menstruated, she'd probably menstruate for about 3 weeks of her cycle because everything has to get through these microscopic little holes in there, right? This is a microperforate hymen. She's got little bitty hole, and it's going to take a long time for her to menstruate. Here's a septate hymen. There's a whole bunch of other variations of hymens. So what is it for? It's just a strip of tissue And unfortunately, historically speaking, it has been used as evidence of a woman's virginity. Yes, but it's not really evidence of a woman's virginity because A, some women don't start out with any appreciable amount of hymen to begin with, and B, there are a whole bunch of ways to damage it. Whole bunch of ways to damage it. You can damage it with inserting a tampon. You can damage it with masturbation. You can damage it with sports. You can damage it with a random accident. You can damage it with any number of damn things, right? So, but either way, when the hymen is damaged, quite often if the woman has some, there's going to be a little bleeding associated with the damage of the hymen, which sometimes occurs during first intercourse and sometimes occurs way before that. So, the hymen, historically and culturally, depending on where we're talking about with cultures, has been used as evidence of a woman's virginity. It has even been used as, for instance, the Virgin Queen, which was one of the Queen Elizabeths. Do you guys remember one of the Queen Elizabeths? So one of the Queen Elizabeths never married, and she was Queen of England, right? But in order for her to hold on to her monarchy, she, every single cycle, every single month, had to have her hymen inspected by the royal physician, or else she had to abdicate the throne. And that is the most powerful person on the planet at that time. So in some cultures, you are not considered marriageable unless your hymen is intact still. In some cultures, they consider, like in Western Europe, historically speaking, in order to show that it was a marriage well made, after consummating the marriage, they would hang out the bloody sheet. Yeah? And women are not dumb. They figured that that was going to happen. They just carried a little sheet blood, squirted on the sheet just to make sure, right? Just in case you didn't bleed, right? Because the alternative was getting stoned to death. So this is still an issue in many cultures. And it's such an issue that now we do hymenoplasty here in the United States. Did you guys know that? We have plastic surgeons that do hymenoplasty. And people come from other cultures usually to here in the United States, although this isn't the only place they do it. You usually take some of the skin from the inside of your mouth and make a little hymen, let it heal, send the woman back, and then the woman is considered marriageable in her culture. So that's actually called a hymenoplasty. And it's really not that uncommon. There are an awful lot of cultures that still require an intact hymen for a woman to be considered marriageable. So this one's really kind of interesting. I don't know why your textbook didn't include it. I think it's culturally relevant. Okay, so everybody okay? All that? Any questions? No?
Is it painful?
Depends on how. I had something else to tell you. So related to that, it depends on how much tissue and how thick it is. It can be painful or it cannot. There's a whole bunch of variability with women. Ask women in your life, right? If they even remember it occurring, right? As long as you're close to them, right? And don't ask your mom. It's going to make her feel weird. My son will probably ask me at some point. I'll be like, no, we're not talking about that. So let me tell you about one of the 562 reasons I'm against abstinence-only sex education. If the woman had an imperforate hymen, sometimes an imperforate hymen will not open when you have intercourse, right? And it actually has to be surgically opened before the woman can have intercourse. But if the woman didn't know that she was supposed to have 3 holes, yes, and her partner didn't know because neither of them had any anatomical or sex education, then what can and does happen, and there are instances in the literature, if you just do a lip search, what happens in that situation is the couple tries to have sex. They don't know what's supposed to be going on down there. They try more than once because, there's a lot of motivation for having sex, and they end up having sex through the urethra. Yes.
How?
Persistence.
I did.
And a little bit.
Sheer persistence.
We heard that in lab about that 80-year-old woman who still had her
Hymen
attached. And
mm-hmm. Yeah, you can do lit search. It sounds like an urban legend until you actually do literature search and physicians actually report this. And when the woman usually goes to the physician about this is because either she's having recurring UTIs for obvious reasons, yeah, urinary incontinence, blood in her urine, yes, and no pregnancies. What? Well, I think everybody knows that hole. Everybody knows where poop comes out, right?
Yeah.
But do girls generally explore the other two? Right?
But it's so small.
It is small, and it probably is a really, really terribly uncomfortable thing to occur. Yes. But this is one of the many, many reasons that ignorance is not the answer. Ignorance is not the answer to virtue. It just never is, right? Right? Virtue is when you know all of the possibilities and you choose the virtuous one. It's not because nobody told you anything else was available, right? So it's just ignorance when you didn't know it was available. So yes, this canon does occur, and you could just do a scholar.google.com search, and you'll find instances in which this occurred. So yeah, it's terrible. It makes every woman in the room go, "Arr!" I think even the men, they're like, I got a urethra, that doesn't sound good. They're like, okay. So one of the two of you needs to have some anatomical and physiological education, or else you cannot keep yourselves safe, right? Okay, so that's an imperforate hymen. Imperforate hymens are relatively rare, and it would have to be the terrible combination of an imperforate hymen and two people with no anatomy and physiology education, right? No sex education at all. Okay, so I'm going to stop, because we didn't get to the male reproductive tract on the other class, and we'll do this next time. If we have any time the next time, I'll teach you guys a little bit about the lymphatic system, but it'll just be a little bit because I want to expose you to it, and there won't be very many questions on your test about it. So the other class is a little bit behind you guys, so I'm going to stop there for today. And also, some of you guys have a test tomorrow.